So Damiano has made my job easier. And again, it's a privilege to be able to work with both of you. So I'm going to briefly talk about, it will be just 10 minutes or 7 minutes because I know all of you are hungry. So as you know, most of the cancer cases that are being diagnosed now, they are in developing countries, and the rate of cancer is going to go up in low-income countries. More than half of the global cancer burden resides in low-income countries. And in fact, if you look at the mortality is dramatically high in low-income countries compared to the high-income countries. As Damiano has pointed out, it is no-brainer. There are a number of factors, including lack of funding, insurance coverage, lack of doctors. For example, one of the physicians, Purvesh Parikh, who is ASMO's international member, he states that in India, they have less than one oncologist per million population. You know what that means? All of New York City, you would have maybe 10 to 15 cancer doctors. All of Seattle, maybe you'll have 5 or 6 cancer doctors. Isn't that amazing? So clearly, they can't do research that many of us are able to do. They don't have protective time to do research because they are overwhelmed to provide services to those patients. Of course, lack of cancer registries. So we simply cannot design a credible cancer plan. So question is, can we treat cancer for $1 a day? I'm an optimist. I'm a cancer doctor, right? So I see optimism everywhere. So I believe, yes, we can. We have to be innovative. Who knew computers would be so cheap now 30 years ago? Who knew internet would be available everywhere? So a number of things that we thought would not be possible now have been possible now. So for example, all these newer molecules like nivolumab, pembrolizumab, and all these targeted agents we talk about, they may become cheaper. We need more innovation. Innovation is the key. So need for palliative care. As you know, most of our patients require palliative care. As a matter of fact, almost 80% of the patients in low-income countries end up requiring palliative care because most patients are diagnosed at a later stage. So what do? We innovate, educate, and advocate to improve healthcare. This is our model, pyramid model. We have limited resources, so clearly we can't take care of all the patients who are at the base of the pyramid. We focus on the top of the pyramid. So we help establish healthcare organizations, healthcare programs. We help train healthcare providers who can train more healthcare providers and who can take care of more patients. For example, this has been one of our beautiful model of collaboration of foundation with a university and hospital in Nepal. And we have been very successful in doing this, as Damiano has pointed out. This physician, he is completing his training, 2 years of training in clinical genetics next week, and he will go back to Nepal. And foundation has sponsored his training, besides other physicians and nurses training. In the interest of time, so our home hospice and palliative care programs, as you all know, each one of us have to die one day. And the way you think, you don't deserve painful death. Nobody should deserve painful death, specifically at a time when pain medicines are so cheap, so effective. So do you know how much it costs to make a morphine pill? Can you just guess? It costs 1 penny. 1 penny. So there is no government in the world who can procure morphine if they really wanted to. So we, as nonprofits, we as healthcare leaders, we as healthcare providers, we must advocate for better access to pain care. We must advocate for better care for patients who are dying. So the way clean air and clean water is basic human right, I believe dignified death, comfortable death, should be a basic human right. So we signed an agreement with Madhya Pradesh government in India to create 51 home hospice and palliative care programs. So I was in India last year. I met with physicians. I saw their hospitals and infrastructure. I met with their lawmakers and bureaucrats, and we signed this agreement. We had this physician, Dr. Chandramouli. He came to Boise. Dr. Walker is here. Can you raise your hand? So he trained, Dr. Walker is a palliative care and hospice physician. He trained Dr. Chandramouli and who went back to India, and 30 patients have been given treatment in last 2 weeks. So it is beautiful to see that our efforts are translating into actual patient care, impacting actual patient lives. So our goal is to create a state-of-the-art hospice and palliative care center, and then make it kind of a major training program for all other healthcare providers in the state. We have recently established another hospice programs in Nepal. So this physician, we trained him, and he recently started his own program there. We will create more home hospice and palliative care programs in resource-poor community. We will create more healthcare facilities or support creation of healthcare facilities to improve cancer care in resource-poor countries. And without all of us working together, without all of us kind of innovating and advocating for this, it would not be possible to take care of more patients who truly deserve care. And many of those treatments are kind of affordable. They are doable. So I would like to ask you, to join us in this pursuit. Thank you.